Welcome to the Deep Dive. Today we're taking on a subject that's, well, often overlooked but is absolutely essential to your overall well-being, the thyroid gland. It's just this small butterfly-shaped organ, right? But as you'll discover in this deep dive, its impact is anything but small.
Absolutely. And we're drawing our insights today from a really comprehensive review. It's titled Thyroid Anatomy, Physiology, and Disease Management by Dr. Rinaldo G. San Luis III.
Okay.
Our mission really is to distill all this detailed medical information into clear, actionable knowledge, give you a shortcut sort of to understanding this fascinating part of your body.
So if you've ever wondered what that gland in your neck actually does or, why it matters so much to your energy levels, maybe your mood, metabolism, you're definitely in the right place.
Let's get into it.
Okay, let's unpack this.
Yeah.
First up, let's actually meet your thyroid.
Yeah.
Where is this little butterfly-shaped regulator hiding, and what does it actually look like?
Well, picture this. It's a firm, reddish-brown, butterfly-shaped gland. It's nestled right there in the front of your neck. Okay.
Usually around the level of the C5 to T1 vertebrae, if you want the specifics, just below your Adam's apple, typically.
Right.
And it has these two distinct sides, the lateral lobes, one on each side, connected by this narrow bridge in the middle, that's the isthmus. And sometimes, maybe about half the time, there's this little extra bit pointing upwards from the isthmus, the pyramidal lobe.
A little pyramid. So it's small then, but sounds like it's well mighty.
Precisely. We're
Right.
talking tiny dimensions, maybe 4 to 4.8 centimeters long,
Yeah.
1 to 1.8 wide, something like that.
Wow.
And the whole thing typically weighs only about 10 to 20 grams.
10 to 20 grams. That's like, what, a couple of coins? For something so vital.
Exactly. Packs an enormous punch for its size.
A bustling little powerhouse. Does that mean it needs a lot of resources, like a super rich blood supply?
It absolutely does. It's one of the most vascular organs in the body,
Yeah.
receives a huge amount of blood flow relative to its size.
That tells you something right there. It really does. It signals just how active it is. Its main fuel lines are the superior thyroid arteries coming off the external carotid artery and the inferior thyroid arteries, which branch from the thyrocervical trunk.
Okay, so blood flowing in.
Right. And then after all that work, the blood needs to get out. And that happens through a network of veins. The superior, middle, and inferior thyroid veins.
It's amazing how much is packed into such a small area. What else is nestled in there? You mentioned it's critical, particularly for something like, say, speaking or singing.
Ah, yes. This is where it gets really interesting, especially if your voice is important to you. The thyroid has some incredibly crucial neighbors.
Like what?
We're talking about nerves that surgeons need to be extremely careful around. Specifically, the recurrent laryngeal nerves, the RLNs, and the external laryngeal nerve, the ELN,
And why are they so critical?
because they control your vocal cord function, your voice. Any surgery in that area demands, well, incredible precision to avoid damaging them.
Wow, so it's not just about metabolism and energy, it even impacts your voice. That's incredible how closely packed everything is.
And what about those parathyroid glands I've heard about? Are they, like, part of the thyroid? That's a really good question. They're actually separate glands, but they live right next door, usually on the back surface of the thyroid.
Okay, so neighbors.
Exactly. Typically 4 of them, these tiny little parathyroid glands. And while they're close, they have a completely different job, but it's equally vital.
Which is?
They regulate your body's calcium levels. It's just another prime example of how tightly packed and interconnected everything is in that small space in your neck.
Okay, so we've met the gland and its important neighbors. Now let's really dive into its inner workings. How does it actually make those critical hormones? You mentioned hormone synthesis, a multi-step process.
Yes, it's like a sophisticated chemical factory operating right inside your neck. And the very first step is something called active iodide uptake.
Iodide, like iodine.
Exactly. Iodide is the ionized form of iodine. Your thyroid gland has this remarkable ability to actively grab iodide right out of your bloodstream.
How does it do that?
It uses a specialized protein, kind of like a gatekeeper, called the sodium iodide symporter, or NIS. This really highlights why iodine, which we get mainly from our diet, think iodized salt, seafood,
Right.
is absolutely essential. It's the raw material.
So iodine is the key ingredient. Okay, step 1, grab the iodine. Once it's inside, what happens next in this chemical factory?
Step 2 is called organification, or sometimes iodination.
Organification.
Okay, here, an enzyme named thyroid peroxidase, TPO for short, gets involved. Think of TPO as a crucial worker on the assembly line. It takes the iodide, oxidizes it, and attaches it to specific spots on a large protein called thyroglobulin.
Spots on a protein.
Yeah, these spots are tyrosine residues, and attaching iodine there creates two precursor molecules. Monoiodotyrosine, or MIT, that's one iodine attached.
MIT, got it.
And diiodotyrosine, DIT, that's two iodines attached.
Okay, MIT and DIT. So TPO is bringing these pieces together. What's the final step to make the actual hormones?
That's coupling. TPO, that same hardworking enzyme, now acts like a matchmaker. It takes two of those DIT molecules and couples them together.
Two DITs.
And that forms thyroxine, which most people know as T4. That's the main hormone the thyroid produces.
T4, okay. And the other one?
And if TPO couples one MIT with one DIT,
That's plus DIT.
that creates Triiodothyronine, or T3. That's the other key thyroid hormone. And it's actually the more biologically active form.
So T3 and T4 are finally made. Where do they go? And how does the body know when to actually release them?
Right, so they don't just immediately flood out. They're actually stored right there within the thyroid, attached to that thyroglobulin protein, in a substance called colloid. Think of it as a reservoir, a storage tank.
Or reserve tank, makes sense.
Then, when your body signals that it needs them, and the main signal comes from a hormone called TSH, thyroid-stimulating hormone,
TSH.
these stored T3 and T4 molecules are cleaved off, cut free from the thyroglobulin, and released into the bloodstream. And then they can travel around the body and do their jobs.
It sounds like a beautifully orchestrated process. But how does the body keep this whole system in check? So it doesn't make too much or too little hormone.
That's managed by a really elegant system called the HPT axis, the Hypothalamic-Pituitary-Thyroid axis.
HPT axis. Sounds important.
It is. Think of it as the command center. It starts way up in the brain, in the hypothalamus. The hypothalamus releases a hormone called TRH, thyrotropin-releasing hormone.
TRH from the hypothalamus.
Right. TRH then travels a very short distance to the pituitary gland, also in the brain.
Okay.
And TRH tells the pituitary to release TSH, that thyroid-stimulating hormone we just mentioned.
So hypothalamus, TRH, pituitary, BioH, TSH.
Exactly. And then TSH travels through the bloodstream down to the thyroid gland in your neck.
And tells it to make T3 and T4.
Precisely. It stimulates the whole synthesis and release process we just discussed.
So it's a top-down chain of command from the brain down to the thyroid. But how does the system know when to, turn the production up or down? Like a thermostat.
That's the perfect analogy. It uses a brilliant self-regulating mechanism called negative feedback.
Negative feedback? How does that work?
It's quite simple, really. When the levels of T4 and T3 circulating in your blood get high enough, those high levels act as a signal. They travel back up to the hypothalamus and the pituitary gland and essentially tell them, okay, guys, we have enough hormone now, you can slow down.
So they inhibit TRH and TSH production.
Exactly. They put the brakes on. This prevents overproduction, stops the system from going into overdrive.
And the opposite happens if levels are low.
Correct. If your T4 and T3 levels drop too low, that braking signal weakens. The hypothalamus and pituitary sense this and respond by releasing more TRH and TSH.
Which then ramps up thyroid hormone production again?
Right. It kicks the thyroid back into gear. It's this constant adjustment, this beautiful balancing act that maintains hormonal balance, what scientists call homeostasis. It really is remarkable how your body fine-tunes this constantly.
That truly is remarkable. Okay, so if this system is so good at self-regulating, how do doctors figure out when something's actually gone wrong? What are the key tests they use to sort of peek inside this intricate balance?
Good question. The first line of investigation is usually blood tests, specifically thyroid function tests.
Right.
The most sensitive and commonly checked one is TSH, that thyroid-stimulating hormone. Remember, it comes from the pituitary.
Okay, TSH first.
Its level tells us a lot about what the pituitary thinks the thyroid is doing. We also measure the actual thyroid hormones circulating in the blood, typically free T4 and sometimes free T3.
Free T4 and free T3. Why free?
Because most T4 and T3 in the blood are bound to proteins. The free portion is what's unbound and biologically active, available to your cells. So measuring the free levels gives a better picture of the functional status.
Got it. So TSH, free T4, free T3. That tells you if it's working too much or too little.
Essentially, yes. Those are the core function tests.
And beyond just function, what about when the body might be, attacking itself? I hear that's a common cause of thyroid problems.
You're absolutely right. Autoimmune conditions are very common culprits. Things like Graves' disease, which causes hyperthyroidism, or Hashimoto's thyroiditis, a major cause of hypothyroidism.
So how do you test for those?
We look for specific antibodies in the blood. For Graves', we often check for TSI, thyroid-stimulating immunoglobulin. And for Hashimoto's, TPO-AB antibodies against that thyroid peroxidase enzyme we talked about are usually elevated.
Okay, so antibodies can point to an autoimmune cause. What about looking directly at the thyroid gland itself, like its structure?
That's where imaging comes in, primarily thyroid ultrasound. It's a really crucial tool.
What does ultrasound show?
It's excellent for evaluating the size of the thyroid, checking for enlargement, like a goiter, and especially for looking at thyroid nodules, lumps or bumps within the gland. It tells us the size, number, and characteristics of these nodules.
And when a doctor looks at an ultrasound, what are they really hoping not to see? Are there telltale signs that make them think, maybe this nodule needs a closer look?
Definitely. While most nodules are benign, there are certain features on ultrasound that raise suspicion for malignancy, for cancer.
Such as?
We look for things like microcalcifications, tiny little spots of calcium within the nodule. Also, irregular margins, meaning the edge isn't smooth and well-defined. And another sign is if the nodule is taller than wide in shape on the image.
Taller than wide. Interesting.
Yeah, these features, especially in combination, increase the suspicion level.
And if a nodule does look suspicious on ultrasound, what's the next logical step?
The next step is usually a biopsy, specifically a fine needle aspiration biopsy, or FNA.
FNA. How does that work?
It's considered the gold standard for checking out suspicious nodules. A very thin needle is guided, usually with ultrasound, into the nodule to withdraw or aspirate a small sample of cells.
And then what happens with those cells?
Those cells are sent to a pathologist who examines them under a microscope. They're then classified using something called the Bethesda system. It's a standardized way to report the findings and estimate the risk of malignancy, from benign to definitely cancerous.
Okay, that makes sense. Now, going back to function for a second to help pinpoint the cause of an overactive thyroid, hyperthyroidism, there's another kind of test involving iodine, right?
Yes, that's the radioactive iodine uptake and scan, often called an RAIU scan.
How does that work?
You swallow a small, safe dose of radioactive iodine. Since the thyroid naturally takes up iodine to make hormones, the scan measures how much of this radioactive iodine your thyroid absorbs over time.
And what does that tell you?
It helps differentiate the causes of hyperthyroidism. For instance, in Graves' disease, the entire gland is usually overactive and takes up a lot of iodine diffusely. In other cases, maybe only one specific nodule is overactive and takes up all the iodine.
Ah, so it shows where the overactivity is coming from.
Exactly. And it helps distinguish between hot nodules, those that are hyperfunctioning and taking up iodine, which are very rarely malignant, and old nodules, which are non-functioning, don't take up iodine and actually carry a slightly higher risk of malignancy if they are solid.
Hot nodules, cold nodules. Got it. Finally, are there specific blood markers used maybe to track certain types of thyroid cancer after treatment?
Yes, there are specific tumor markers we monitor. Thyroglobulin, or TEAG, is a big one. Remember thyroglobulin, the protein where hormones are made? Normal thyroid cells make it, but so do most differentiated thyroid cancer cells, like papillary and follicular cancer. So after the thyroid is removed for cancer, TG levels should ideally be undetectable. If they start to rise later, it can signal a recurrence.
Okay, so T for monitoring common thyroid cancers. Any others?
Yes, there's calcitonin. This is a different hormone, normally made by specific cells in the thyroid called C cells. Calcitonin is a key marker for a less common type of thyroid cancer called medullary thyroid cancer, or MTC. It's used for both diagnosis and monitoring MTC.
Okay, that's quite a diagnostic toolkit. So sometimes, despite all that brilliant self-regulation, the thyroid just, well, doesn't work quite right. Let's talk about the common conditions when the thyroid goes awry. Starting with hyperthyroidism, too much thyroid hormone. What does that actually feel like for someone?
Yeah, hyperthyroidism means your body is essentially stuck in overdrive. Excessive thyroid hormone leads to a hypermetabolic state.
Overdrive. So like,
Think fast heartbeat, palpitations, feeling anxious or jittery, maybe losing weight even though you're eating more, tremors in your hands, feeling hot and sweaty all the time, maybe trouble sleeping. It can really impact quality of life.
that sounds pretty disruptive. How is it managed medically?
The main medical approach involves antithyroid drugs. We mentioned them earlier. Methimazole, or PTU, propylthiouracil.
Right, they block hormone production.
Exactly. They inhibit that TPO enzyme. We also often use beta blockers like propranolol, especially early on.
Why beta blockers?
They don't fix the thyroid problem itself, but they're great for rapid symptomatic relief. They help calm down that fast heart rate, the tremors, the anxiety, while the antithyroid drugs start working, which can take a few weeks.
Okay, so drugs can manage it. What about more definitive solutions beyond taking daily medication?
For a more permanent fix, there are two main options. One is surgery, a total thyroidectomy, removing the gland entirely.
Remove the source of the problem.
Right. The other is radioactive iodine ablation, that RAI treatment we discussed as a diagnostic scam, but used at a higher therapeutic dose.
So the radioactive iodine destroys the overactive tissue.
Precisely. It targets and destroys the overactive thyroid cells. Both surgery and RAI are very effective, but they usually result in the opposite problem, hypothyroidism, afterwards.
So you often end up needing hormone replacement therapy for life then?
That's typically the case, yes. Lifelong levothyroxine.
Okay. Now on the flip side, let's talk about hypothyroidism, insufficient thyroid hormone. This sounds like the opposite problem, the body running too slow.
Exactly. Hypothyroidism results in a slowed metabolic rate. It's often more insidious, develops slowly.
What are the symptoms people might notice?
Things like persistent fatigue, feeling sluggish, unexplained weight gain or difficulty losing weight, feeling cold when others aren't, dry skin, hair loss, constipation, maybe brain fog or difficulty concentrating, even depression sometimes.
Also sounds quite impactful. How is this one managed? Is it just hormone replacement?
Pretty much. The standard of care is thyroid hormone replacement therapy using levothyroxine. That's the synthetic T4 hormone.
Just replacing what's missing.
Exactly. The goal is to give you back the hormone your thyroid isn't making enough of. The dose has to be carefully adjusted, titrated based on regular blood tests, mainly TSH, to get the level just right. And yes, it typically requires lifelong therapy.
So if it's usually just about replacing a missing hormone, is surgery ever involved in treating primary hypothyroidism?
Generally, no. Surgery isn't indicated for primary hyperthyroidism itself because the issue is a lack of hormone production, not usually a structural problem that needs removing.
Unless
Unless the hypothyroidism is caused by something like Hashimoto's thyroiditis, which over time can sometimes lead to a very large goiter, an enlarged thyroid gland. If that goiter becomes so large that it starts causing compressive symptoms.
like trouble breathing or swallowing?
Exactly. Difficulty breathing, difficulty swallowing, voice changes. In those rare situations, surgery might be considered to remove the enlarged gland and relieve the pressure, even though the underlying issue was hypothyroidism.
Makes sense. Okay, beyond these functional issues, too much or too little hormone, the thyroid can also develop structural abnormalities or even new growths, neoplasms as you call them. What happens if someone has, say, a benign nodule or a goiter that isn't causing hormone problems?
Right, and that's very common. Most thyroid nodules are actually benign. If a nodule is confirmed benign after an FNAB, or if a goiter isn't causing hormone issues or compression, the usual approach is active surveillance.
Active surveillance, so just watching it.
Essentially, yes. It means monitoring with regular checkups and periodic thyroid ultrasounds, maybe once a year or so, to make sure the nodule or goiter isn't growing significantly or developing suspicious features.
And when would surgery be considered for these benign conditions?
Surgery for benign nodules or goiters is typically reserved for specific situations. One is if they do start causing those compressive symptoms we just talked about, difficulty swallowing, breathing, voice changes. Another is if the goiter grows downwards into the chest, that's substernal extension, which can be risky. Or sometimes if the nodule keeps growing despite being benign, or if the FNAB results come back as suspicious or indeterminate, meaning not clearly benign or malignant, and occasionally for significant cosmetic concerns.
Okay. Now, shifting to thyroid cancer. If cancer is diagnosed, how does the treatment strategy usually unfold? You mentioned surgery is key.
Yes, for almost all types of thyroid cancer, surgery is the primary cornerstone treatment. The main goal is to completely remove the tumor.
And what kind of surgery? Does it always mean removing the whole thyroid?
Often, yes. A total thyroidectomy, removing the entire gland, is the standard procedure for most differentiated thyroid cancers, especially if they're larger than a centimeter or have concerning features. It's also standard for medullary thyroid cancer.
But not always the whole gland.
Not always. For very small, low-risk papillary thyroid cancers, say less than a centimeter, and confined to one lobe with no spread, a lobectomy removing only the affected lobe and the isthmus might be a sufficient option. This is something discussed carefully with the patient.
And what if the cancer seems to have spread nearby, like to the lymph nodes in the neck?
Good point. If lymph node involvement is suspected before surgery, based on ultrasound or other imaging, or if it's confirmed during the operation, then a lymph node dissection is also performed. This means removing the affected lymph nodes in the central part of the neck, or sometimes the side of the neck, depending on the extent of spread.
Okay, so surgery first. What happens after surgery for cancer? Is that it?
Not always. Depending on the specifics of the cancer, its type, size, stage, and the patient's overall risk of recurrence, further treatment might be recommended.
Like what?
One common postoperative treatment, especially after a total thyroidectomy for differentiated thyroid cancer, is radioactive iodine ablation.
RAI again. Why use it after surgery?
The goal here is to destroy any tiny remnants of normal thyroid tissue that might inevitably be left behind after surgery, and more importantly, to destroy any microscopic cancer cells that might have lingered in the neck or spread elsewhere. It sort of cleans up the area.
Okay, so RAI to clean up. Anything else?
Yes, another crucial part of postoperative medical management for thyroid cancer is TSH suppression therapy.
Suppression. You mean keeping TSH low?
Exactly. Remember how TSH stimulates thyroid tissue? Well, it can also stimulate the growth of many thyroid cancer cells. So after surgery, patients are typically given a slightly higher dose of levothyroxine than they would need just for hormone replacement.
Why higher?
The goal is to suppress the pituitary's TSH production, keeping TSH levels very low, sometimes even undetectable. This helps reduce the risk of any remaining cancer cells growing or the cancer recurring.
Makes sense. And are there other treatments for very advanced cases?
Yes, for advanced metastatic or refractory thyroid cancers that don't respond well to surgery and RAI, or for types like anaplastic cancer, newer targeted therapies and sometimes chemotherapy or external beam radiation might be used. These are usually managed by specialized oncology teams.
Okay, that gives us a good overview of the conditions and treatments. Now, let's zoom in a bit more on the specific pharmacological toolkit, the actual medications used. Starting with levothyroxine, T4, you said it's the go-to for hypothyroidism. How exactly does it work again?
Right. Levothyroxine is basically synthetic thyroxine, identical to the T4 your own thyroid makes. It's the standard first-line treatment for hypothyroidism because you're just replacing the hormone that's missing.
And the mechanism.
It's pretty straightforward. Take the pill, it gets absorbed, and it circulates as T4. Then, your body's tissues in various cells convert that T4 into the active T3 form as needed. This T3 then enters the cell nucleus, binds to specific thyroid hormone receptors, and regulates gene expression, basically turning on all the metabolic processes that thyroid hormone controls.
So it restores function at the cellular level.
Precisely. It gives your body back the signal it needs to run properly.
Okay. Now, for hyperthyroidism, we heard about antithyroid drugs, methimazole, and PTU. How exactly do they put the brakes on an overactive thyroid?
Their primary job is to treat hyperthyroidism by reducing that overproduction of hormones. They do this by directly inhibiting the enzyme thyroid peroxidase, TPO.
That key enzyme in making the hormones.
The very same one. By blocking TPO, they effectively stop the organification step, adding iodine to thyroglobulin, and also the coupling step, joining MIT and DIT to form T4 and T3. They shut down the factory's main assembly line.
Got it. And you mentioned there's slight differences, like PTU sometimes being preferred in pregnancy.
Yes, there are some specifics. PTU is generally preferred in the first trimester of pregnancy because of slightly lower risks compared to methimazole during that specific window. PTU also has an additional minor effect. It partially blocks the conversion of T4 to the more active T3 in the peripheral tissues outside the thyroid.
Interesting.
However, outside of that first trimester pregnancy situation, methimazole is generally the preferred drug. It has a slightly better safety profile overall, especially regarding liver toxicity risk, and it can usually be taken just once a day, which is more convenient for patients.
Okay. We also talked about radioactive iodine ablation several times now as a diagnostic post-cancer treatment and a definitive treatment for hyperthyroidism. Can you recap how a radioactive substance actually treats these conditions?
Sure, RAI ablation uses a specific isotope, iodine-131, I-131. The cleverness lies in the thyroid's unique hunger for iodine. When you administer I-131 orally, usually as a capsule or liquid, it gets absorbed and concentrated specifically in thyroid cells, whether they're normal, overactive, or cancerous thyroid cells. Other cells in the body largely ignore it.
So it's very targeted.
Extremely targeted. Once inside the thyroid cells, the I-131 emits beta particles, a type of radiation that travels only very short distances, just a millimeter or two. This radiation damages and ultimately destroys the cells that absorb the iodine while sparing surrounding tissues.
So it selectively destroys the problem cells from the inside out.
Exactly. Whether it's overactive cells causing hyperthyroidism or residual normal or cancerous cells after surgery.
But you also mentioned the long-term effect is often hypothyroidism.
Yes, that's the common outcome, especially when used to treat hyperthyroidism like Graves' disease or after total thyroidectomy for cancer. By destroying the thyroid tissue, you eliminate the source of the problem, but you also eliminate the body's ability to make its own thyroid hormone. So, lifelong levothyroxine replacement becomes necessary. It's a trade-off for a definitive cure.
Okay. Then there's propranolol, the beta blocker. This seemed a bit different. It doesn't fix the thyroid itself, right? What's its role again?
Correct. Propranolol doesn't target the thyroid gland or hormone production directly. It's used primarily for rapid symptomatic relief in hyperthyroidism.
For those symptoms like fast heart rate and tremors.
Exactly. Many of the uncomfortable symptoms of hyperthyroidism, palpitations, rapid heartbeat, tremors, anxiety, heat intolerance, are caused by the excess thyroid hormone making the body overly sensitive to adrenaline and noradrenaline. Propranolol works by blocking the beta-adrenergic receptors that these stress hormones act on.
So it blocks the effect of the stress hormones that are amplified by the thyroid hormones.
Well, precisely. It helps calm those symptoms down very quickly, often within hours, providing relief while waiting for the anti-thyroid drugs, or RAI, to take full effect. And as a small bonus, at higher doses, propranolol also slightly inhibits that peripheral conversion of T4 to T3.
Okay, symptomatic relief. Got it. And finally, let's revisit those intriguing iodine-based agents. We established iodine is essential for hormone production, but here, in high doses, it's used to stop it temporarily. How does too much of an essential ingredient become a treatment?
It is a fascinating paradox, isn't it? This is known as the Wolff-Chaikoff effect.
The Wolff-Chaikoff effect.
Yes. When thyroid cells are suddenly exposed to very high concentrations of iodine, much higher than usual, it triggers an acute temporary shutdown of hormone synthesis and release. It effectively stuns the thyroid's production line for a short period, maybe a week or two.
Why would you want to do that?
It's used in specific, usually short-term situations. For example, in managing thyroid storm, which is a rare but life-threatening surge of thyroid hormone, the high-dose iodine helps rapidly decrease hormone release. It's also often used preoperatively for patients with Graves' disease who are undergoing thyroidectomy.
Why before surgery?
Because besides inhibiting hormone release, high doses of iodine also decrease blood flow to the thyroid gland, making it firmer and less vascular. This can make the surgery technically easier and safer for the surgeon. But it's crucial to remember this effect is temporary. The thyroid eventually escapes the block.
So a powerful but short-term break. Very interesting. Okay, we've covered a lot of ground. Let's circle back to surgery. When is a total thyroidectomy, the complete removal of the gland, really deemed necessary? Sounds like a major intervention.
It definitely is a significant operation, and the decision is never taken lightly. But there are clear indications. Malignancy or thyroid cancer is probably the most common reason.
Which cancers specifically?
For differentiated thyroid cancer, DTC that includes papillary and follicular cancers, the most common types, total thyroidectomy, is generally the standard of care if the tumor is larger than 1 centimeter, if it shows high-risk features like spreading outside the thyroid capsule, or if there are cancerous nodules in both lobes. Multifocal disease.
Okay. What about the less common, maybe more aggressive types?
For medullary thyroid cancer, MTC, total thyroidectomy is indicated for essentially all cases, regardless of size, because MTC has a higher tendency to spread to lymph nodes early. So it's often done along with removal of the central neck lymph nodes, either prophylactically or therapeutically.
Right.
And even for anaplastic thyroid cancer, ATC, which is very aggressive and often difficult to treat, surgery might sometimes be considered, usually for palliative reasons, like if the tumor is causing severe airway compression and removing it could improve breathing, assuming the disease hasn't spread too widely yet.
So cancer is a major driver. But it's not just about cancer, is it? Total thyroidectomy can also be indicated for benign, non-cancerous conditions.
Absolutely. A big category here is benign disease causing significant symptoms.
Like that compression we talked about.
Exactly. If you have a large multinodular goiter or even a single large benign nodule that's physically pressing on your trachea, causing difficulty breathing, dyspnea, or pressing on your esophagus, causing difficulty swallowing dysphagia, or impacting those recurrent laryngeal nerves, causing voice changes. Surgery to remove the gland can relieve that pressure.
That makes sense, removing the physical obstruction.
Another related indication is substernal extension. That's when a goiter grows downwards from the neck into the upper chest cavity, behind the sternum.
Growing into the chest, that sounds risky.
It can be, yes. It poses risks of sudden airway compromise or compression of major blood vessels in the chest, so substernal goiters usually warrant surgical removal.
The other benign reasons.
Occasionally, yes. Very large goiters or nodules, even if benign and not causing compression, might be removed for cosmetic reasons if they are significantly disfiguring and cause distress to the patient. And sometimes, if an FNA result is repeatedly indeterminate or suspicious, surgery might be recommended for a definitive diagnosis, even if cancer isn't confirmed.
Okay. And finally, what about functional disorders? Can hyperthyroidism itself be a reason for total thyroidectomy?
Yes, definitely. While medication and RAI are common treatments for hyperthyroidism, surgery is a valid and sometimes preferred option.
When would someone choose surgery over the other options?
Well, it's an important option if medical therapy with antithyroid drugs fails, meaning the hyperthyroidism isn't controlled, or perhaps the patient relapses after stopping the drugs. Or, critically, if a patient experiences severe adverse reactions to the medications, like a granulocytosis, which is a dangerous drop in white blood cells, or liver toxicity, if you can't tolerate the meds, surgery becomes a key alternative.
Okay, so if meds aren't working or aren't safe?
Right. Also, some patients simply prefer a definitive, rapid cure. They might want to avoid long-term medication, the need for ongoing monitoring, or the potential side effects of RAI. Surgery offers that quick resolution, especially appealing for people with Graves' disease, particularly if they also have eye symptoms, or those with large, toxic multinodular goiters where RAI might be less effective or require very high doses.
So patient preference and specific circumstances play a big role too.
Absolutely. It's always a shared decision-making process between the patient and their medical team.
Wow. We have certainly taken a real deep dive today into the thyroid. It's just amazing how this small gland truly has its, well, hands in almost every system of your body, doesn't it?
It really does, from setting your metabolic rate, influencing your heart, your brain, your temperature.
Even your vocal cords, as we learned. Its quiet work is just profoundly important.
It really highlights how interconnected our physiology is. And understanding that intricate balance, the HPT axis, the detailed steps of making hormones from simple iodine, and then all the ways we can diagnose and manage when things go wrong, it really gives you an aha moment, I think, about the body's incredible capacity for self-regulation.
Exactly. So, thinking about all this, what does it all mean for you, the listener? Given how this seemingly small, unassuming butterfly-shaped gland can have such a massive impact on your entire well-being. Makes you wonder, doesn't it? What other unassuming parts of your body might be quietly orchestrating crucial functions you often take for granted?
That's a great point.
And how does understanding these intricate biological feedback loops, like the HPT axis, maybe change the way you think about maintaining your own overall health?
Definitely something to chew on until our next deep dive.